and then no. No, I don't want somebody else controlling the computer. Okay.
Are you a sailor?
There you go. And then
Below deck?
if you want to. Forward and back with the arrows.
Okay. All right, thanks. It's more of an homage to the the show Below Deck. I don't know if anyone's seen that. Anyway, yeah, it's quality TV. Sometimes you don't want to think too hard when you're at home.
Well, so we're really lucky to have our own Dr. Whitehead giving a lecture that he did present at the Fetal meeting. A lot of us were not able to be there, so we're very excited to have you do this again. It's an area that confuses us all. We're learning a lot, but I think more questions get raised, the more you learn. So thank you for.
Absolutely. Thank you for inviting me to do this talk. All right, so we'll be talking about the posterior fossa. I have no disclosures. All right, so to set the stage, let's review a postnatal, relatively mature, normal MRI of the posterior fossa and its contents. All right, so you have the brainstem, midbrain, pons, medulla. The pons is about twice the size of the midbrain. Pons has two components, the basis pontis and pontine tegmentum. The back of the brainstem and front of the vermis are roughly parallel to one another. The tegmentovermian angle is about 0 here. That can go up to about 18 degrees and still be normal. You can see there's a sharp vestigial recess of the fourth ventricle shaped by the nodulus of the vermis. This is located just below the midpoint of the pons. The vestigial declive line divides the vermis roughly into a 2-to-1 ratio below and above. And the height of the vermis extends from about the mid-tectal plate and approaches the level of the obex. Note the occipital bone here along the floor closely approximates the undersurface of the cerebellum, leaving only a small space, the cisterna magna. Unlike in the fetus, when this cisterna magna can be quite capacious, although typically less than 10 millimeters. And this is to accommodate the massive growth of the vermis that's occurring over the second and third trimesters, the fastest growing structure in the brain, growing about 34-fold during that period of time. So this can really fool you if you kind of, to the untrained eye, that there's an enlarged cisterna magna, and that's why cerebellar biometry is so important. A recent study showed that if there's a discrepancy of the expected height of the vermis by more than 4 millimeters, or if the inferior vermian distance is greater than 4 millimeters, that portends a worse prognosis for the patient. Okay, so the learning objectives here to review normal embryologic development of the cerebellum, brainstem, meninges, and meningeal spaces to help improve understanding of posterior fossa pathology, and to introduce a pattern approach for those pesky posterior fossa fluid collections. All right, so obviously posterior fossa disease is challenging. We're looking at small structures that really challenge the current, resolution of our imaging, and those structures are in motion almost constantly. There can be parenchymal malformations or insults that mimic them. Fluid collections range from normal to pathologic. Often the imaging pattern is characteristic, but we really need to understand some basic embryology to really figure out the differential diagnosis fundamentally. So how does fetal MRI do? So posterior fossa anomalies account for about 1 in 5,000 births. Obviously that number is larger in the fetal period. It's the second most common reason for fetal MRI. The first would be ventriculomegaly. Now, the prognosis really depends on, obviously, the type of anomaly and whether or not they're associated or additional abnormalities. So, for instance, if you have a megacisterna magna in a postnatal developmentally normal child with no other problems, that's an incidental finding. A megacisterna magna in a fetus without knowing anything else is indeterminate. And so a megacisterna magna, 20% of those can have additional abnormalities, and of those, a third can have chromosomal aberrations. So we really need to figure out if there's anything associated with the megacisterna magna, and that's where MRI is really well suited to do that. In fact, this recent literature has suggested that MRI outperforms ultrasound when it comes to posterior fossa anomalies. Here you can see that the diagnostic yield goes from 65 to 88%, with a 3-fold reduction of high confidence incorrect diagnoses. So on the basis of this, these authors mentioned that the posterior fossa anomalies found on ultrasound warrant an MRI. So anatomy here. So here on the left we can see a midline sagittal T1, and on the right parasagittal. Note the difference in the appearance of the vermis versus the cerebellum. The cerebellum has uniformly radiating fissures and folia, unlike the sort of arborization pattern of the vermis here at midline. So in the midline vermis we see distinct vermian fissures, that angulated fourth ventricular fastigial recess, and the fern-like morphology. Not to get into too much fine detail on the anatomy of the vermis, but just point out a couple things here. First, note how the inferior vermis and superior vermis, the fissures and folia are different, and they look smaller on the inferior vermis, so that should not be confused with inferior vermian hypoplasia. So this is just the normal appearance. Second, the fissures here, the primary fissure is a common fissure to see. That should be visible basically at all times on fetal MRI by 18 weeks. And then there's the prepyramidal fissure, which is probably the second most visible vermian fissure here. It should be visible by 21 to 27 weeks. If you do 7 Tesla MR imaging of fetuses, obviously after death, these fissures can become visible even a month earlier than that. All right, so, but one thing that I do when I kind of look at the cerebellum is I look for the vermian speed bump, as I like to call it, or bow tie knot. So you can see in the axial and coronal plane that how the fissures and folia extend to this sort of bump in the road here, or knot in the bow tie. So that's should be visible on all the fetal MR imaging. Okay, so on to embryology. So let's take a look at this kind of simplistic depiction of growth and development of the fetus from implantation to birth, divided into trimesters. You'll notice that most of the action in terms of posterior fossa happens in the latter 2/3 of the first trimester, just after the brainstem's segmentation happens. That's when the cerebellum is born, from intense neuroblastic activity at the rhombic lips and ventricular zones, usually about rhombomer 1, 2, and the isthmic organizer. That's sort of when this is happening at about 4 to 5 weeks here. Now, that's when the cerebellum is born, but it has a quite protracted growth. And in fact, neurons are still dividing and forming up to 1.5 years after birth. So this protracted growth pattern places at risk for a number of different insults. One thing to keep in mind. Simultaneously, the meninx overlying it is transforming into the meninges and subarachnoid spaces. There's an interplay between the meninx and the cerebellum, where if you have an impairment of the meninx for any reason, you can have malformations of the cerebellum. Then the foramen of Magendie will form. Unknown time period, sometime between 44 days and 4 months, but usually most people think it should be about by 8 weeks. There's a period of neuronal migration, and then by the end of the first trimester, the cerebellum is extraventricular and the torcular is in normal position. So notice that anything that happens to the posterior fossa, enlarging the posterior fossa in the first trimester, can cause a torcular elevation, and torcular elevation is not specific to a Dandy-Walker malformation. You can see it in any sort of cyst or even Cisterna magna. So let's take a look in more graphic detail about the things that are happening at the end of the first trimester here. So at 5 to 10 weeks, at this point in time, the mesenchyma has insinuated itself into the roof of the fourth ventricle, separating the anterior from posterior membranous areas.
Excuse me, are these embryonic or menstrual weeks?
That's a good question. I don't know. But
I would bet it's menstrual weeks.
Yes,
like
I think most of these are, yes.
Yeah.
I'd have to go back and just double check on that. So at this point, basically, you have the rudiment of the cerebellar vermis will grow down and incorporate the anterior membranous area. If for some reason there's arrested development of the vermis, you get the Dandy-Walker malformation. In this situation, the cerebellar vermis, what does develop, will be separate and distinct from the choroid plexus. So if you analyze the wall of a Dendi Walker quote cyst, there should be no choroid plexus in its wall. Later, like I said, from 44 days to 4 months, the Blake pouch will evaginate from the posterior membranous area, eventually perforating to form the foramen of Magendie. If this is delayed, or if the foramen of Luschka do not open entirely, you can get a Blake pouch cyst. Some people think that these posterior fossa septa are the correlate to the Blake pouch or Blake pouch cyst in development, although I think that's debatable. And if the Blake pouch cyst has a delayed perforation, you can get a Cisterna magna. That's sort of the thinking there. So now moving back to this diagram, at about 15 weeks, the cerebellum will be formed, and then later on, the foramen of Luschka will perforate. People estimate this to be about maybe 16 weeks, although it's unknown, and in 20% of humans, it may not open at all. And so this obviously has implications for things like Dendi Walker malformation and Blake pouch cyst. So for instance, a Blake pouch cyst, it's thought that 50% of them can go away by 25 weeks, and maybe this has to do with delayed opening of the foramen of Luschka. Okay, so by 18 weeks, and this is maybe the first time a patient would come to fetal MR imaging, we should see the fastigial point of the fourth ventricle. There's my arrow. Primary fissure, and a covered fourth ventricular roof. Now, notice that I have two images here. Why is that? Well, I couldn't get both of these things on one image, right? So it's very difficult at 18 weeks to kind of pick these things up. And it's unusual to even see a distinctly angulated fourth ventricle. But if I see that one is sort of forming, and I can make out a difference between the top and mid part of the vermis there, I say that that's probably early fissuration. So basically, even by 18 weeks, again, here's a normal sagittal, coronal, and axial image. I should see the primary fissure, which is here, a forming fastigial recess, and the speed bump or bow tie knot that represents the cerebellar vermis in the coronal and axial plane. And so over time, you can see how we see all those structures and the cerebellum grows, but those all should be present on every image. Also, again, this particular slide took me hours to put together because it's very, very difficult to find good quality sagittal, coronal, and axial normal anatomy in a fetus. Yeah.
Sorry to interrupt. On the 18-week ones in the top half,
yeah,
there's three little black dots.
Right.
Almost like there's things
yes.
spinning around. What are those?
Yeah. So the two here in the top and the mid part, those separate the primary fissure. So this is just the anterior vermis, or also superior vermis forming, and then the neovermis here posteriorly. This is going to be the nodulus, the dark part here, which is going to shape the lower fourth ventricular floor and form the fastigial recess. Nice. Yeah. All right, so on to the pathology of the posterior fossa. Roughly, these can be considered as cysts, insults, hindbrain malformation, and tumor. All right, so for cysts, any classification of cysts, really, the gold standard is to kind of assess the wall of the cyst. And so, for instance, arachnoid cyst will have arachnoid membrane. Blake pouch cyst will have several things, including choroid plexus. Remember the proximity of the posterior membranous area to the choroid plexus. Dendi Walker will have neurons, but no choroid plexus. And now, we don't really analyze the wall of the cyst on imaging, but we can usually gather the type of cyst based on the appearance and location. And one note is to think about the fact that, probably many cysts go undiagnosed both in life and death. And that's, because it's very hard to see the cyst walls on imaging, and so we look for secondary signs of mass effect. And then even on pathology, you have to carefully dissect the posterior fossa, submerge the posterior fossa underwater to expose the delicate membrane, which will rise up to see that. So unless that's done correctly, you might not get a positive finding on neuropathology. Okay, so arachnoid duplication cyst. This is a duplication of the arachnoid membrane, somewhere between 5 to 10 weeks of gestation. Here's a 24-week sagittal T2 weighted image. And what do we know? Well, the Cisterna magna looks enlarged. So that's the first thing. The question is the cerebellum too small, or is there something causing mass effect in the posterior fossa here? So if we look at the other images, there is some slight deformity along the back of the cerebellum, and also the falx cerebelli looks hypoplastic. Usually you see a linear membrane kind of approaching the back of the vermis here. And in the coronal plane, we can actually see this obliquely oriented kind of thin septation or membrane in the posterior fossa. So now I think there's something occupying the posterior fossa and pushing on the cerebellum. This looks like probably an arachnoid cyst. This is a cautionary tale. Typically, arachnoid cysts don't change over time. They can get smaller, they can enlarge, but this patient was counseled to come back for head ultrasound. And brace yourself for the next slide. This is when they finally returned at 14 months, had marked enlargement of this cyst, more compression of the cerebellum, and hydrocephalus. This was fenestrated, and they clinically improved. All right, so the next disease is Blake pouch cyst, and that's, again, a failed perforation of the normal Blake pouch, somewhere between, after 44 days and 4 months, or failed opening of the foramen of Luschka. And if you remember the embryology, we talked about how this is really associated with the posterior membranous area, and the posterior membranous area approximates the choroid plexus. So very often you can see the choroid plexus along what would be the wall of the cyst, and you can see this like linear dark area coming off the bottom of the vermis that represents choroid plexus being dragged out into where the cyst would sit. Also note that the tegmental vermian angle here is increased to 33 degrees. So that's not normal. 18 would be the upper limit of what would be normal. Typically in a Dendi Walker malformation, it's over 45 degrees. In a Blake pouch cyst, it's under 30 degrees. This is kind of in the middle. But if you look at the cerebellum, it's otherwise normal. And here again, that normal road bump, the vermis in the middle. Nice reassuring sign that the cerebellum is formed normally. If you look closely on the coronal, you can kind of see this curvilinear membrane representing the wall of the Blake pouch cyst, and then this may be the choroid plexus here along the lower part of the cerebellum. Just the blue arrows, these little dark hypointensities. And here's what it looks like on the ultrasound. So this is a Blake pouch cyst. Blake pouch cysts may or may not have hydrocephalus, but that may be one thing you can see with Blake pouch cysts. Here's a neonatal MR of a patient with a Blake pouch cyst, and I think you can appreciate the membrane here coming off. Mildly increased tegmental vermian angle. That can be normal, and you can still have a Blake pouch cyst, but notice on the post-contrast where you can see choroid plexus here, this irregular enhancement along the undersurface of the vermis. Okay, and then the enlarged Cisterna magna. One brief word on this. As a word purist, it's hard for me to kind of like come to terms with this term, although I realize with semantic drift, we have to kind of realize that, words will change meaning over time, because this term was originally applied to in the late 60s by Gossett and colleagues to apply to a cerebellum that is small from volume loss and secondary ex-vacuole enlargement of the Cisterna magna. But now it's sort of come to represent an enlarged Cisterna magna and an otherwise normal cerebellum. So it's sort of a diagnosis of exclusion in some ways. So here's a 29-week fetus, and we can see that the Cisterna magna is quite enlarged. The cerebellum is otherwise normal, and also notice the elevation of the torcular. So again, any process that enlarges the posterior fossa can enlarge the torcular. It's not specific to the Dendi Walker malformation. And yeah, sure.
Keep interrupting you, but some people say that the measurement is from the bottom of the vermis to the top of the foramen magna. Yeah,
I mean, I think traditionally the measurement is where, on the axial ultrasound, those would typically be measured. But, realize the axial plane on ultrasound is very variable. So it's sort of in general, and I think we should probably kind of look at that closely, and maybe we need to redefine the boundaries, as we move forward here. But clearly this one, no question, it's not an equivocal case, very marked enlargement of the cisterna magna. Often with these, you'll have abnormalities of the falx cerebelli. In this case, it's sort of elongated. It's longer than you typically see. Sometimes it can be duplicated, triplicated, quadruplicated, and these can be a sign of, mesenchymal malformation, in terms of the development of the posterior fossa. So this is in a patient with an otherwise normal cerebellum, the enlarged cisterna magna or mega cisterna magna. On to the fibrous arachnoid cyst. This is a type of arachnoid cyst from a prior inflammatory process, can be from prior infection or hemorrhage, typically hemorrhagic in nature. Here in the sagittal T2-weighted image, you can see that the cisterna magna is quite enlarged. There's some mass effect along the cerebellum. If you look in the ventricle, you can see some hypointensity representing prior hemorrhage. And here, just very irregular, multiple septations and adhesions in the posterior fossa, segmenting the fluid spaces here, mass effect on the cerebellum, ventriculomegaly, hydrocephalus, and intraventricular hemorrhage. And on the T1, sometimes it's helpful to improve our diagnostic accuracy for hemorrhage. Or you can see increased signal representing methemoglobin. What it looks like on ultrasound. Yes?
Is it a spectrum of like a trapped fourth, or you'll call it a fibrous arachnoid?
Well, trapped fourth means that that the fluid can't get out and it can't get in from the top and bottom, right? So the fourth ventricle is markedly expanded. You have aqueductal stenosis and you have fourth ventricular outflow stenosis. So here the fourth's not really that enlarged. I wouldn't really call it trapped, but we definitely have adhesive process that's obstructing or at least impeding CSF flow. So on to insults. So here we have, start with parenchymal infarct. In this 19-week-old fetus on this coronal and axial T2 images, you can see that the transverse cerebellar diameter is decreased, and it seems to be a deficiency of the left cerebellar hemisphere. So on to MRI, this is now postnatally, we can see that there's actually marked encephalomalacia and volume loss of the left cerebellar hemisphere. And so most of these, what look like they could be unilateral cerebellar hypoplasia, actually represent prior insults, either infarctions or hemorrhages with secondary encephalomalacia. You can see the vermis here relatively intact. The prognosis is variable. They can be normal to markedly impaired depending on the surface area involved and whether or not the vermis is involved or spared. On the gradient echo, you might see some faint susceptibility here from old hemorrhage, and this patient actually had a duplicated posterior pituitary gland with a secondary focus of bright signal in the median eminence. So sometimes disruptive or hemorrhagic cerebellar hypoplasia can mimic Dendi Walker. Here's a case that that we described in the literature, which on the sagittal T2, you can have, it looks like the cerebellar vermis is hypoplastic and under-rotated, and the tegmental-vermian angle is increased, although the torcular is not quite elevated. But if you look closely, you can see what looks like hypointensity here, which probably is old blood products. And then on the postnatal MRI, clearly this is a large corncephalic cyst from a prior injury. All right, then there's infection. Obviously, the most common neonatal prenatal infection in the torch category would be CMV. CMV rarely affects the posterior fossa, so I'm not going to show that. I'm going to show this case instead. Rarely. Can. That's what the literature says. And so here's this case instead, where you can see this patient with marked underdevelopment hypoplasia of the cerebrum, ex-vacuole enlargement of the ventricles, and cerebellum relatively spare, but brainstem was hypoplastic. And so this patient had a travel history to El Salvador. This was Zika virus infection. A third of them will affect the posterior fossa. Most of those are from prior like insult or injury to the cerebellum or brainstem, although in this case we have hypoplasia. Then there's dural venous sinus thrombosis. In this 21-week sagittal T2 weighted image, we can see marked hypointensity and enlargement of the torcular here. On the T1, we have increased signal, and here it is in the axial T2. And on the gradient echo, we have blooming. So this is intravascular thrombosis in the torcular, representing sinovenous thrombosis. Now, these do quite well, actually, or can do quite well. And you'll notice that the cerebellum and cerebrum in this case was normal. And on the postnatal, we had recanalization and no ill effects on the cerebellum or cerebrum. So patient did well here. For malformations, the Chiari malformation, Chiari 2 malformation, that is, so in this case we have imbalance between the amniotic fluid and the intrathecal fluid, and you don't have the normal gradient of pressure because of the myelomeningocele. So secondarily, the brain vesicles don't expand, the torcular doesn't implant normally, and the cerebellum is sort of, in a small space, so it can be ectopic both superiorly and inferiorly. Also, you have a mesodermal dysplasia, and you'll note you can see on the MRI the lemon and banana sign here. On the sagittal plane, really not much of a cerebellar ectopia at this point at 22 weeks. You can still see the cisterna magna fluid space here, and there's the myelomeningocele. But at 32 weeks, now we have, after the cerebellum has grown into its cistern and inferiorly, we have more cerebellar tonsillar ectopia and more crowding of the cerebellum. So this can happen over time. The Walker-Warburg syndrome, in this scenario, this is an alpha dystroglycanopathy. There's lack of a protein responsible for neuronal migration, so they get severe brain malformations affecting the cerebrum, cerebellum, and brainstem. One cardinal feature here is this Z-shaped brainstem. So when you see that, that really kind of brings up these congenital muscular dystrophies that affect the brain. The only other two things in that differential really are the tubulinopathies and L1 CAM, although those don't tend to have this sort of severe brain malformation, and also the eyes tend to be spared with those disorders. But you'll see, because of the malformative change in the diencephalon and midbrain, you have aqueductal stenosis. Marked hydrocephalus is quite common. Now, they get a cobblestone lissencephaly. Very difficult to appreciate that, if at all, in fetal. So the absence of seeing any cobblestone change in the brain doesn't exclude that diagnosis for sure. And also notice the Z-shaped brainstem really, in addition to being, a malformation, it really could be viewed as, a very primitive or hypoplastic development of the brainstem. This is a normal 11-week-old MRI from a patient or from a fetus, and you can see this normal. It's normal to have this sort of Z shape of the brainstem early on. Postnatally, the Walker-Warburg syndrome, again, the Z-shaped brainstem, marked malformation. Now we start to see that cobblestone lissencephaly, where the outside of the brain is smooth, the inside has an irregular look where the neurons have over-migrated. They can have ocular abnormalities. In this patient, there's persistent fetal vasculature, these linear hypointensities behind the globes, and the cerebellum is markedly malformed with multiple cysts. The diencephalic mesencephalic junction malformation, that is a failure to attain a normal embryonic boundary, and so you have an anterior-posterior patterning defect between the diencephalon and midbrain. And so you can see this is the thalamus, this is the midbrain. They are connected in union and not separated. Obviously, because of this, again, you can get an aqueductal stenosis and hydrocephalus, as we see here. Very commonly, the posterior fossa doesn't develop normally, posterior fossa structures, so you can see hypoplasia of the brainstem and cerebellum here. Very little cerebellar tissue is present. The rhombencephalosynapsis is a dorsoventral patterning defect, and we can see some degree of absence of vermis you can have a complete rhombencephalosynapsis where there's no vermis in contiguity of the cerebellar hemispheres, or you can have a hypoplastic vermis and partial union of the cerebellar hemispheres. Here in the axial and coronal plane, you can see, again, midline contiguity of the fissures and folia, and I don't see the normal bow tie, the normal knot of the vermis, so I know there's something wrong here. On the sagittal midline, you can see that the fastigial recess is rounded rather than its normal pointed look, and you can also appreciate aqueductal stenosis inferiorly. So just to remind you, again, what the normal cerebellum should look like, you should see the bow tie knot here in the middle representing the vermis, and here's the normal fastigial recess on a sagittal midline T2. So the bottom line here is when you see what could be a rhombencephalosynapsis, you need to check for aqueductal stenosis and vice versa, because they tend to go together based on the embryology. The Dendi-Walker malformation. For this, to fulfill the diagnosis of a classic Dendi-Walker malformation, you need a vermis that's either aplastic or hypoplastic and counterclockwise rotated, so increased tegmental vermian angle, markedly enlarged, cystic appearing fourth ventricle, and enlargement of the posterior fossa. Anything less than this is not really in the Dendi-Walker malformation, but rather could be part of what people would describe as the spectrum. The overarching theory here, again, is that there's arrested development of the rhombencephalon, the anterior membranous area fails to regress, and you get expansion of the fourth ventricle through the anterior membranous area. Here's a coronal ultrasound, and we can see that the Cisterna Magna looks big. The cerebellar hemispheres look splayed apart. Looks the same on the MRI. You can appreciate the edge of the fourth ventricles here by these membranes. And in the axial plane, again, it kind of looks like a boomerang to me. That's the way I kind of tend to think about it. And here it is on the sagittal plane, markedly increased tegmental vermian angle. And abnormal vermis, right? So it's not normally formed. The height is shortened. So this is something in the Dendi-Walker kind of field. The torcular is a little elevated here. And postnatally, kind of they look the same. Here you can again appreciate a very hypoplastic vermis, blunted fastigial recess, enlarged fourth ventricle, uplifting of the torcular. The Joubert syndrome, I mentioned this one because especially early it can be confused with Dendi-Walker malformation. It's an autosomal recessive ciliopathy, can affect the brain, liver, kidneys, and eyes. And so, but they tend to have cerebellar vermian hypoplasia, dysplasia. So that's why they can be confused with Dendi-Walker malformation, but have a different appearance. This is a postnatal MR, and you can see that there's some mild hypoplasia of the undersurface of the vermis. This is the edge of the vermis, and this is actually cerebellar hemisphere, volume averaged at midline. There's some slight thinning of the lower midbrain, which is a quite subtle finding. But if you go to the parasagittal T1, you can see thickened, horizontally oriented superior cerebellar peduncle. And then lower down, we have apposition of the cerebellar hemispheres rather than being splayed apart like we see in Dendi-Walker malformation. And then the cardinal feature of Joubert syndrome, the molar tooth malformation of the midbrain. So here's a 19-week fetus with Joubert syndrome, just to show you how difficult this can be. What we see is the Cisterna Magna looks big, the vermis looks small. You'd want to do biometry and measure that and see if that's small. It turned out to be hypoplastic. Also, the tegmental vermian angle was increased. Can we appreciate a molar tooth malformation here? Again, very tough, very difficult. If you don't have the right plane, it's very hard to say. Sometimes the sagittal T2 can be helpful here. I think that's probably a thickened, horizontally oriented superior cerebellar peduncle. This patient had a renal dysplasia and hypothalamic malformation, so this fit into the form of orofacial digital syndrome type 6. Most of these don't have good genotype-phenotype correlations, although this one might. So when I think about posterior fossa cysts and related disorders, this is sort of the way I kind of like deal with them. The first order of business is the cerebellum normal or not. If the cerebellum is normal, then that gets you into a different category. If the vermis is hypoplastic and the vermis is hypoplastic and malrotated and splayed, or is the vermis dysplastic and the hemispheres are opposed. In the latter category, if you have the molar tooth malformation, Joubert Syndrome. In the middle category, if the torcular is inverted, that's Dandy-Walker malformation. If not, you're in the continuum or spectrum, or however you want to describe it. Then if you have chorioplexus along the cyst wall, increased tegmentovermian angle, plus or minus hydrocephalus, lake pouch cyst, and then the diagnosis of exclusion here with only enlarged cisterna magna, normal cerebellum, is the megacisterna magna. And so quickly on to pontocerebellar hypoplasia. So with the pontocerebellar hypoplasias, you could have the genetic forms, or you can have an insult or some sort of diminished substrate delivery which impairs the growth of the cerebellum and vermis. So can be difficult to sort of set those things apart. Most of the genetic pontocerebellar hypoplasias are not visible this early on. They tend to develop later as the cerebrum sort of outgrows the cerebellum and vermis, and then they become visible. And we don't have great, again, phenotype-genotype correlations other than the TSEN54, which has the dragonfly cerebellum. So here's a type of a pontocerebellar hypoplasia. Here's the sagittal, axial, and coronal T2, and we can see that the cerebellum is small and the cisterna magna is secondarily enlarged. Very irregular appearance to the brainstem, where you kind of have this vaulted appearance here posteriorly. Postnatally, we can see a slight vaulted appearance of this very irregular hypoplastic pons. Again, the vermis is hypoplastic as well. So this is pontine tegmental cap dysplasia. Another type of pontocerebellar hypoplasia can happen with chromosomal abnormalities. Here we see the cerebellum is hypoplastic. In this patient, there's a cephalocele here posteriorly. And the sagittal plane, again, pons and cerebellum are hypoplastic. There's a posterior cephalocele. On the T1, you can actually see that there's hypoplasia of many of the cervical vertebrae as well. Coronal T2 shows absence of olfactory bulbs and tracts. So this is arachnoencephaly. So if you put all these things together, this is a patient with a trisomy 18, which is the second most common trisomy. They get brain microdysgenesis, including posterior fossa hypoplasia and pontocerebellar hypoplasia. They can have neural tube defects and may have signs of holoprosencephaly or arachnoencephaly. Here's a patient with a trisomy 21, which we commonly see pontine hypoplasia. It's not often that visible in fetal. Occasionally you'll see it, but you don't see the normal bulge of the anterior pons here. And finally, tumor. Tumors are very rare, obviously, in fetal life, and most of them are going to be supratentorial tumors, unlike postnatally in children, they tend to be posterior fossa tumors. There was a recent study of 27 fetal tumors. All of them originated in the supratentorial compartment. 2 of them did span into the posterior fossa. Those were teratomas. In this case, we have a sagittal, coronal, and axial T2-weighted image showing marked enlargement and hypointensity of the lower brainstem, pons and medulla. And so it's very hypointense on T2 and a lot of restricted diffusion. So this looks like a tumor of the brainstem with very hypercellular tumor of the brainstem, probably an embryonal tumor. And postnatally, the patient hemorrhaged and developed worsening hydrocephalus. So this, we didn't get pathology on this, but we suspect this is some, high-grade embryonal tumor of the brainstem. All right, so in conclusion, posterior fossa anomalies are common indications for fetal MRI. We can classify most of these by appearance, and the prognosis depends on the type, presence, or absence of additional anomalies, and that's where I think MRI is really helpful in sorting those out. There's, again, my quick case of the Dandy-Walker and related disorders, and so how I look at them. The most important thing is to assess the cerebellum and whether it's normal or not. All right, here's my mini references, and thank you very much.
Thank you so much. It was just easily, but within 10 minutes, you are normal. If there's anyone out there listening, you can unmute and ask a question if you're interested. Those who've called in. And if not, are there any questions from the room? You know it all.
No. Matt, so you made a point that by about end of the first trimester, the torticula should have come to its resting place. How is it that, I mean, I think most people think of the Blake's pouch cyst only really starting to, does it like literally lift up the torticula and move it north?
Yeah, I think it's not, it's still in flux in terms of its permanent position, and it's still, the meninges and mesenchyma are still in development at that period of time, and so if you have a pressure effect in the posterior fossa, that implantation can be more cephalad than typical. I think that's sort of the thinking.
Yeah, I've been held onto that torticular position as being what's defining for me in terms of a Dandy Walker. And then you come along and you my last.
Right, because I mean, right, the case of the Mega Cisterna Magna, right? Clearly, the cerebellum is normal. The patient doesn't have a Dandy Walker malformation, and yet the torticular is elevated. Now, it may not be elevated to the extent of above, the lambda, where the lambdoid sutures and sagittal suture come together, but elevated nonetheless, I think.
But is that part of a sort of mesenchymal neurodermal interaction that's gone awry, and those are two separate events, or does? Yeah,
I think it's unclear. I mean, I think there are probably more than one explanation as to why the torticular can implant higher than it should. Yeah.
This notion of it actually being uprooted and repositioned. I'll get over it. Yeah, lovely.
Thank you.
Thank you. Any other questions? Joubert, any comments?
No.
Like that?
What about one more?
Yeah.
What do you think of the theory that I think Ashley Robinson has, that a proportion, some or all of the transient lateral ventricular megaly that we see, so the mild, the benign variant, where you go to 12, 13 maybe, and then it normalizes. He thinks that delayed fenestration of the Blake's pouch cyst, it plays a role there, that there is either a drag on the efflux of the CSF or a block, and then as the delayed fenestration happens, the ventricles just kind of glide down to their normal size.
I mean, I think that's plausible. I don't think there would be any way to refute that argument. It seems reasonable to me. Yeah.
No one systematically looked at, obviously, right. Not that I'm aware of, but I find that interesting.
Yeah, absolutely.
So even if you don't see a bulge there, the dynamics of it.
Right, and I mean, the other thing, to realize is you can have a Mega Cisterna Magna, and there well could be a cyst in that Cisterna Magna, and you'll never know it again unless, like, you have.
CSF flow studies, man.
Yeah, those sort of things. But yeah, occasionally, and occasionally you're right. The ultrasound might show the cyst wall, the MR can't, but there are often times where you might not see it at all, And the other kind of concept that I kind of come back to sometimes is, what if you have a diverticulum? So, you might have, what was a cyst, and still the walls of what was the cyst present in the Cisterna Magna, and if you did a flow study, maybe the flow is actually okay there. I mean, maybe we're talking academic now, and it doesn't matter anyway because you've got free flow into and out of what was a diverticulum, but I feel like you can have diverticula as well of a previous cyst. So, still a lot to work out and a lot to explore in the posterior fossa. Yeah.
Yeah, no.
Right, that's true. Yeah, it's more of pulsatility, right?
Thanks again. Great.
Thank you.
Everyone, Just sign in,
Thanks, Phil.
get Julie credit, and I'll have a wonderful Thanksgiving.